Fluorescein dye and the ocular surface. Where it stains, where it doesn't, and why it matters. Fluorescein dye is a simple yet powerful tool for diagnosing a range of ocular surface disorders. In this video, we'll explore the dynamics of the dye, the mechanism, and various clinical applications. The standard method of applying a fluorescein dye is through sterile, single-use fluorescein impregnated paper strip. Saline or 0.5% of proparacaine is placed onto the tip of the strip. Any excess dye on the strip should be gently shaken off to prevent overstaining before applying it to the lower palpebral conjunctiva. Fluorescein absorbs blue light at 465 to 490 nanometer and emits green fluorescence at 520 to 530 nanometers. A cobalt blue filter is used to excite the dye. Adding a yellow filter blocks the scattered blue light and enhances the contrast, making the green fluorescence stand out more clearly, as seen in these slit lamp images. The corneal epithelium consists of multiple structured layers: basal cells anchored to the basement membrane, suprabasal wing cells, and superficial squamous cells. At the superficial layer, the important tight adherence junction create a semi-permeable hydrophobic barrier which has molecular components that regulate cell-to-cell adhesion and permeability. In contrast with the hydrophilic nature of the fluorescein dye, it allows selective passage of tear components while normally preventing fluorescein penetration. In scattered damage to the superficial epithelial cells with loss of tight junctions, these cells may undergo apoptosis or desquamation, resulting in focal uptake of fluorescein. The staining appears as multiple small dot-like areas, each representing the site of superficial cell loss or disruption. These are what we call the superficial punctate keratitis. In contrast, a true epithelial defect represents a contiguous area of epithelial loss, exposing the underlying basement membrane. Fluorescein pools uniformly in this denuded zone. Additionally, microcystic edema presents as negative staining, where fluorescein outlines the elevated cystic space but does not enter them. Moving on to the clinical implications, fluorescein can differentiate staining patterns seen in superficial punctate keratitis. In thygosine superficial punctate keratitis presents with multiple coarse round to oval epithelial lesions that stain with fluorescein. These lesions are often central and bilateral. Microsporidiosis presents with coarse raised white epithelial lesions that show irregular fluorescein staining. More extensive epithelial involvement presents as confluent staining in true epithelial defects. For example, in this patient with post-penetrating keratoplasty, there is a near total epithelial defect. Seedles can also be performed to detect a leak. This video shows Seedles test being performed on a leaking desmetocele. As we move further, limbal stem cell deficiency can be diagnosed with a fluorescein stain. In this pattern of stippled conjunctival staining, fluorescein stain can also reveal a demarcation line separating the clear cornea and the stippled cornea, indicating a partial LSCD. This helps us assess the extent of LSCD. In advanced LSCD, the corneal surface appears dull and irregular, which is lusterless, often showing stippled late fluorescein staining. Dry eye evaluation involves both functional and structural assessment of the tear film and the ocular surface. Fluorescein dye helps visualize the tear meniscus along the lower lid margin. It's a crude method to assess the volume of aqueous in the tear film. In a normal eye, it's around 0.2 to 0.4 mm, while in a dry eye, it's less than 0.25 mm. Another dynamic method to assess tear film stability is the tear breakup time, or the T-BUT. After instilling the fluorescein dye, the patient is asked to blink several times to evenly spread the dye. T-BUT is then measured as the interval between the last blink and the first appearance of a dry spot on the corneal surface. A value less than 10 seconds is considered indicative of tear film instability. In direct assessment of tear secretion, fluorescein dye helps assess real-time lacrimal gland function by highlighting the tear production. To perform this test, stain is gently applied to the superior palpebral conjunctiva near the lacrimal gland opening. The patient is asked to blink normally. The appearance and movement of fluorescein streaked tears on the ocular surface is observed. The timing, length, intensity of the fluorescein trail helps assess the real-time secretory response of the lacrimal gland. In this patient with Sjogren's syndrome, fluorescein staining in yellow filter before cautery revealed temporal, nasal, inferior and superior conjunctival grade 3 staining, which improved post-cautery. Another undiagnosed entity of dry eye is the hidden lid viper epitheliopathy, which is a friction-related damage. In the image on top, we can visualize a widened strip of staining along the superior lid margin associated with conjunctivocalluses and grade 2 bulbar conjunctival staining. Interestingly, the lower lid also shows a lid viper epitheliopathy, which is relatively uncommon finding. It's equally important to recognize the broader spectrum of ocular surface disorders. Redundant conjunctival folds may disrupt the tear film. Fluorescein highlights these folds by pooling between them, often seen near the nasal conjunctiva. Filamentary keratitis presents as strands of mucus and epithelial debris adherent to the corneal surface. Fluorescein stains the base of these filaments, vividly highlighting them. In Stevens-Johnson syndrome, the keratinized surface of the lower lid margin appears elevated, causing negative fluorescein staining. The lid margin keratinization can also lead to mechanical trauma of the cornea. In VKC, giant papillae form on the upper lid. Staining of the central core indicates an active papillae. Finally, a last note on infections. Dendritic ulcers are characterized by linear branching pattern with terminal bulbs which are highlighted by the fluorescein stain. In conclusion, fluorescein staining is more than just a diagnostic tool. It acts like a magic wand for the clinician, revealing what the naked eye cannot see. From subtle tear film instability to epithelial defects, keratinization and infections, highlights the hidden disruptions on the ocular surface. This simple dive brings clarity to complexity, illuminating the path to precise, targeted care.